case with you where we scanned fetal echo at 23 weeks of gestation, had some positive findings, re-reviewed the patient on 28 weeks, and then follow-up of a neonatal echo, and let us see what were the findings. Now, in the three-vessel trachea view, you see this is superior vena cava trachea. This is aorta and pulmonary artery. Both are actually forming the V, and the flow is antegrade, but the aorta is smaller than the pulmonary artery. Apart from that, then you have a flow acceleration across the aortic valve. Now we're not sure whether this is mild aortic stenosis which has led to a smaller aorta here, or there is an additional coarctation of an aorta. Look at the velocities of across the aortic valve, crossed 90 centimeter per second against a normal of around 70 at this gestation. And then you see the z-score as the isthmus are smaller, but they are not, they are still less than -2, they are -1.76. The pulmonary artery z-scores were normal, the aortic peak velocities were high. With the suspicion of a coarctation of aorta in addition to aortic stenosis, we thought let's review the patient. We did that after 5 weeks of gestation, and what we found was the aorta become still more smaller as compared to the pulmonary artery, which is confounded by the z-score. The aortic isthmus z-scores dropped to -2.56, and that's a real good yardstick of knowing whether the isthmus stenosis is progressing or not. So it did progress over gestation. So this is the smaller aorta, which is less than half of a pulmonary artery diameter. So I think we are now definitely dealing with the coarctation of an aorta, while you see there the ascending aorta is not as small as compared to the isthmus. So now there is increased velocities, which as the gestation grew increased to 1.2 meters per second. But the aortic ascending aorta z-scores are also small, but not as bad as isthmus z-scores. We recommended this baby to be delivered in the tertiary care unit. The parents declined and got a delivery done at a usual place, and we found that the parameters were fine. Systolic murmur was there, and there was a weak femoral found by the neonatologist, and neonatal echo was done on day 3. Now you can see the aortic annulus is small, aorta is smaller as compared to LA and LV. That's how you compare the aorta here. And then you see the aortic valve is thickened with an eccentric kind of closure. You see there is increased velocities across the aortic valve, but they're not looking like aortic stenosis. You have a bicuspid aortic valve here, one cusp and another cusp. So this bicuspid aortic valve, but there is opening of the valve is fine. It doesn't seem like a severe aortic stenosis. So we are dealing with a mild thickening of the valve, no significant aortic stenosis. But on a suprasternal view, what you find here is a tortuous aorta, and this tortuous aorta, there is an increased systolic and diastolic continuous flow velocities across this coarced segment, and there is a post-coarcted segment dilatation. And if you do a continuous wave Doppler, you see the gradients across the coarcted segment as the velocity is 4 meters per second, and the gradients are 74 millimeters of mercury, which indicates a severe coarctation of aorta, which was confirmed. So now what do we do here? Should we do a balloon dilatation or we do surgery in coarctation in neonates? The patterns are that in case there's a comparison of various study which says that mortality thou is little higher with the surgical repair, but the issue is that the complication rate with the balloon angioplasty is very high, something like 12% if we do a balloon angioplasty here. So it's not, and the freedom to re-intervention also is not there. In about 65% patients they required surgery. So now the recommendations are in a neonate or infants less than 6 months, irrespective of the anatomy, surgery should be done, or more than 6 months in a young children in case you can do a balloon angioplasty post surgery. And if there is a discrete native coarctation, you can consider doing a balloon angioplasty. Otherwise, it's an idea to do surgery in a younger neonates and balloon valvuloplasty or aortoplasty later. Yes, I think it's a good idea to subscribe the channel. I'll keep on posting new videos, insights for your pursuit.